Welcome to the Robert and June Becker Health Policy Lecture. I'm John Meurer. I'm the director of the Institute for Health and Society. Our institute is the sponsor of the Becker Lecture. Our mission is to improve health and advance equity through academic and community partnerships and through the integration of medicine and population health. Robert Becker was a physician who graduated from the Marquette University School of Medicine, which eventually became the Medical College of Wisconsin. He was a founder of the Joint Council of Allergy and Immunology, a practicing allergist, and founder of Healthcare Compare, which was transformed into First Health. I actually worked at Healthcare Compare while I was in business school in Chicago and moonlighting at Children's Memorial. He also served on the board of the National Association of Peer Review Organizations, so had a national leadership roles in his work in managed care and in peer review. And he was really a very committed person to service, quality, and efficiency in transforming our healthcare delivery system. In 1999, First Health offered an endowment to the Medical College of Wisconsin for the Becker Lecture. And the special guest we had hopes of joining us today, Dr. and Mrs. Becker's son, Scott, and his wife, Mudgeon, and Jacob, unfortunately can't join us because of a health illness in their family. Dr. Meyer is this year's Becker Lecturer. Greg is the Chief Clinical Officer and Executive Vice President for Population Health at Dartmouth-Hitchcock Medical Center, pictured in the upper right. He's also Senior Associate Dean for Clinical Affairs and Paul Batalden Professor and Chair at the Geisel School of Medicine. And I grabbed a quote from Theodore Geisel Seuss, Dr. Seuss. And Greg is past Senior VP for the Lawrence Center for Quality and Safety at Massachusetts General Hospital, and got a nice image of that by the water. Prior to those important leadership roles, Dr. Meyer was the medical director of the Massachusetts General Physicians Organization, which is the largest physician group practice in New England. And one of the most extraordinary accomplishments in his leadership role there was the Medicare Care Management Demonstration Program that both improved quality and achieved savings for elderly population. He was a previous director of the Center for Quality Improvement and Patient Safety at the Agency for Healthcare Research and Quality, and in that role served on a multitude of committees focusing on improving healthcare quality, including serving on the board of the Joint Commission, the National Committee for Quality Assurance, the World Health Organization, the Institute of Medicine, the National Patient Safety Foundation, and even the National Aeronautics Space Administration. And you'll see why in a moment. Greg was associate professor at the Uniformed Services University of Health Sciences, served as division director of general internal medicine, he's an internist, and also colonel in the U.S. Air Force. In his journey in education, he earned a Master of Arts in Health Policy and Management at Harvard School of Public Health, and also a master's degree and was a Rhodes Scholar at Oxford University in the United Kingdom, and earned his medical degree at Albany Medical College in New York. So please welcome Dr. Meyer.
Thank you. Thank you, John. I think one summary of that would be that I'm basically a monument to overeducation, and I think that that's okay. First of all, let me begin by thanking the Becker family in absentia for having this lecture, and most importantly, thank you to all of you for hosting me here. What I'm hoping to do in the next 40 minutes or so is to help put the last decade in a context and give a little bit of a sense from a policy perspective, where are we going and what the challenges are for those of us who work in quality, who work in safety, who work in trying to manage healthcare organizations, and who are working in population health. And to begin with, where I would start is I'd actually like to take you back to your high school biology class. And if you think back to high school biology, I'm hoping that you all learned about evolution. And when you were learning about evolution, what we learned then, by and large, was the theory of Darwin, and it was best expounded by a Professor Dworkin, who said that the way that we create new species is a lot like the butterflies on your left, in that there are itty-bitty changes, mutations, that take place generation after generation over eons, and those gradual changes lead to new species. And that was the prevailing theory. It was called gradualism. But then Stephen Jay Gould looked at the fossil record, and what he found is some areas in the speciation that looked a whole lot more like the right, where you had a very dramatic change over a relatively short period of time. And he went on to describe the fact that those instances where you see such a dramatic change over a short period of time, something that he called punctuated equilibrium, were times where there was a really conspiratorial confluence of all of these forces, these perfect storms that created rapid changes in the environment, and you had a lot of change over a very, very short period of time. And what I would argue to you is that we are now blessed and burdened by living in what I think is the time of punctuated equilibrium in healthcare. And one of the points that John didn't mention, and that was kind of him, is I was one of those evil people who exactly 20 years ago worked in the Clinton administration and tried to reform our healthcare system. So I was one of them. And that was a big swing and a miss at best. And when I think back on that, there were many reasons for that, and I can talk to you more about that afterwards. But one of the reasons was that, frankly, that the conditions weren't there. The environment wasn't such that was pushing for such a rapid change over a short period of time. But we're living in that time where we're more like the butterflies on the right, and there are lots of reasons for that, including changes in Congress, including the global economic crisis that's ongoing. But we are living in a period of punctuated equilibrium. Here's another way to think about it, and this is some work that I did with some colleagues back at Mass General. One of the things that Mass General does well, and I'd like to think that Mass General did a number of things well, but one of them is they kept incredible records. And the records go back to when the doors of the hospital opened in 1821. And those records included looking at in-hospital mortality. And what you can see here is you can see these in these kind of the fuchsia line here. This is the in-hospital mortality of Mass General over a period of a little over 180 years. And what you can see by looking here is if you look during the 19th century, for those of you with pretty sharp eyes, you'll be able to notice a couple things. Most of these spikes here are actually secular phenomena. These are, for example, these are a set of cholera epidemics that took place in Boston. For those of you with really sharp eyes in the back, you will see right here, that is the flu pandemic of 1917, 1919. There are a couple of other interesting phenomena here in the 19th century. Many of you will see here this rise that took place. It began in 1846. So are there any anesthesiologists in the audience? Okay, seeing none. Oh, 1846, what happened? Ether, the world was freed from pain. And where did that first get applied? At the MG? Under dispute. Well said. October 1846. First public demonstration was at the MGH. Now what you can see here, though, is that as the surgeons start to use ether and do a wider range of treatments and do more surgeries other than just the basic amputations and removal of bladder stones, there was a bit of a learning curve in terms of mortality. Now, if you look here, what you'll see is that during the 20th century, you see this drop in mortality, and this is kind of the medical industrial complex and all those changes that we see taking place, and with many more patients coming to the hospital with Medicare, you can see some spikes here. But then you see a relative flattening. Now, the blue diamonds are how much it cost. So we had cost data going all the way back to 1821, put it into $2,012. And what you can see here is during the 19th century, whether you lived or died in the hospital had a lot more to do with things going on outside of the health care that was delivered to you, and you kind of got what you paid for. You didn't pay for very much, but you didn't get very much. You see in the early 20th century, the start to rise in health care costs, and then a steep rise with the introduction of private health care insurance, a steeper rise again with Medicare. And look at the last decade. Now, you don't have to be an economist to know that this is, in fact, the definition of the law of diminishing returns. That we're spending an exponentially increasing amount, and I am the first to argue that hospital mortality is not a great measure of quality, but look at over a 180-year period, I think there is something very profound about where we are right now in terms of the value equation. And some of the root causes of this are well known, and the top illustration here is the work of Jack Wimberg and others. We just celebrated 42 years of Jack Wimberg's career at Dartmouth looking at variations in healthcare. His first papers were published in the early 1970s in Science. And what's interesting is that we all have now known for those 40 years, those of us who are policy wonks, that where you get your care is highly determinative of how much care you're going to get. And this actually is looking at the last 6 months of life, so the outcome for all the patients is exactly the same. They're all dead in 6 months. And if you go back 6 months and say what kind of resources were expended, you can see that there are some relatively low-cost parts of the country, and you can see that there are some relatively high-cost parts of the country. Outcomes exactly the same. Another friend of mine, Atul Gawande, captured this in a New York article, and this actually made a lot of my physician colleagues angry, and because there was this picture, and the picture was the patient as an ATM, with the notion that you can just go to the patient and make withdrawals to generate your income. So this variation phenomenon has been out there for a very long time. So why are things different now? And part of it has to do with the cost. And you all have seen these cost curves before. I think some that are especially important here is just to, there's a great parlor trick if anyone says, what is the healthcare, what's the rate of healthcare inflation in any year after 1950? You can answer that question, and it is always 2.5% above the consumer price index. So it's eating up more and more. I think one of the other important illustrations here, though, I just want to point out, is this looks at the rate of the growth in healthcare expenditures, and this goes up to $4 trillion here. 6.3% aggregate growth rate. The red line is without the Affordable Care Act, and the blue line is with it. So there's not a huge, big change there with what we're currently going through in healthcare reform. So it's important to recognize that that may be a first step, but it's really not addressing the underlying problem. And here's the way that many of us feel this problem every day. And that is if I put on my hat as a former federal government official, what I would say is I would look at the budget and I would say, oh my goodness, we're spending so much on Medicare and so much in the state matching program for Medicaid. This is getting unaffordable. We're losing our ability to spend money on education and infrastructure and other important programs. This is unsustainable. And then I put on my hat as somebody trying to run a health system at Dartmouth, and what I would say is, oh my goodness, the feds are paying us so little for our care, and we can't rob Peter to pay Paul anymore and pass off those cost commercials. That's unsustainable. And the problem is both of those statements are true. That's the problem. Both of those statements are true. There's another piece to it too, and that is that we need to recognize that in many parts of America, including where I am, that healthcare is dominant. It is the #1 employer in the area. And so whenever we talk about changing healthcare, yes, we need to get those costs under control. Yes, we need to ensure the quality is there. But the reality is that it is impacting not just the lives of those in healthcare directly, but it impacts local economies in a profound way. And say, well, why did it take us so long to get around to trying to tackle these problems? Because it's really hard. Not only is it hard, it has a really dramatic impact on the rest of the economy. So why now? Why are these changes coming in this last decade? And I think that it's important to think about just the last 5 years or so. And all of you will remember back in the kind of scary days in 2008 when the big three automakers were behind closed doors in Detroit, when the United Auto Workers were bargaining with management. Were they in there talking about how to build nicer cars? How to build cars with better mileage? How to cut down costs in the plant? No. They only talked about one thing. They talked about healthcare benefits. That's what they talked about behind those doors. Here's another way to put it. How many folks here have known that we are now going on 5 years, this is the 5th year running, that Starbucks spends more on healthcare of its employees, than it does on coffee beans? Did you know that? That's true. Starbucks spends more on the health care of its employees than it does on coffee beans. That's what's different. That's why this is different than 20 years ago. Because those charts that Jack Wemberg put together and showed variation across America, yep, policy wonks like me, we knew them, we looked at them. Now employers are looking. What's happening is in companies around the country is that the CEO is calling in the head of human resources and saying, hey, listen, I need you to change the way you purchase. Because when I have my coffee bean buyers come in here, I know that they can go to Indonesia and get this really fancy coffee that runs through the GI tract of civet cats, which is the world's most expensive coffee, or they can buy Robusto beans that are relatively cheap from Central America, and I can sell them at different price points, and I'm buying on value, on perceived quality. I need you to do the same in healthcare. That's what's different. That's what's driving this. And so what I'd like to do is I'd like to try to spend a little bit of time trying to tease that out a little bit and putting the last decade of that evolution in perspective. One of the things I think is important to recognize is that there's this shorthand for value, and it is it's quality divided by cost. But it's important to recognize that what you see as value depends a little bit on where you sit. Because as somebody who's in kind of a healthcare provider, if I think of myself of trying to run a healthcare system, I want to maximize the health of the population because it's the right thing to do. And to me, I want to make sure that health care that I deliver is appropriate. I'm giving patients what they need, that I do so with really great outcomes that matter to patients. I do it in a way that shows that they have caring for the patients, and that I do it with the minimum amount of work. I try to make this as lean as I possibly can. The equation's a little bit different if you're an employer, because what you're really focused on is you're focused on how much does it cost to insure an employee for me? What's the total cost of ownership? You're focused on presenteeism. Yeah, it's great if they're healthy, but what you really want them at work, and you want them working. And if you're a individual patient or consumer, what you care about is you care about not the total cost, you care how much it costs you. How much am I going to be paying out of pocket for this? How much is my deductible going to be? So when we talk about value, it's important to recognize that there are nuances to the perspective, but there are some generalities about what's been happening with the way that we've been thinking about value in the marketplace over the last decade. And this is a model that I borrowed from a colleague, Arnie Milstein. Arnie's now out at Stanford. Arnie used to work for Mercer Worldwide Consulting, and he was kind of the health benefits consultant to the stars. He was the one that the Fortune 50 companies came and said, help us figure out this problem of how to purchase based on value. And he said, well, the first step in this evolution is what we ought to do is we ought to just have performance disclosure. People ought to know what they're getting, so that when I go to buy a car, I can decide whether or not I'm going to be able to kind of afford a Scion, maybe, or maybe I have a little bit more money and I want something a little fancier, and I'm going to buy a Toyota, and maybe I'm going to have a little bit more, and I'm going to buy myself a Lexus. I'm making a value judgment. I'm purchasing based on performance, based on something that I think says, yep, here's what I know what I'm going to get. And we've had some experimentation going in that in the last decade. But it's not so easy. And so here's an example. This is the MGH in Boston. And the MGH was ranked a couple of years ago. They were #1 in the country. And for last year, they were #2, according to the U.S. News and World Report. Second best hospital in the country. And in fact, their partner institution, the Brigham and Women's, was #8. So boy, they was a pretty terrific place. But if you went to Health Grades, a place that many consumers would go to look for healthcare information, what Health Grades would say is they'd say, there were 7 Health Grades awards in Boston, and the Mass General didn't get one of them. So they were the #1 or #2 hospital in the country, but only #9 in Boston. That seems awfully confusing. And then you go to, okay, I'm going to go to state government. Right? They're the definitive source. So you go to the Attorney General's website, and the Attorney General will say there are big differences in what hospitals get paid, but the quality's all the same. So people are confused. So this notion that we're just going to put the performance out there and it's all going to work out, it's a little bit of a myth. It really hasn't worked out that way. And one of the reasons is it's not so easy. And here's an example. And this has to do with, is for the pediatricians in the room, and this is looking at if we were opening up congenital aortic stenosis, if we were opening up a tight heart valve in a young child, that what we know is that if you stretch that heart valve out as much as you possibly can, that there's a much better chance that that kid's going to be playing soccer in high school. We also know that if you use a smaller balloon and you don't stretch the valve so much, your chances of killing the child are lower. So if you want to maximize the opportunity that that child's going to go and play high school soccer, you'd use a big balloon. But if you want to minimize the chances they're going to die in the hospital from the procedure, you'd use a smaller balloon. Which is right. If you're a pediatric cardiologist or a pediatric cardiothoracic surgeon doing this procedure, what do you think you're going to do in a state that's going to publish your performance on inpatient mortality? What do you think you might do if you were in a state that was going to publish your performance based on the long-term functional outcome of the kids? Complicated. There's no right answer here. But the point is that this quality measurement piece, it's confusing by nature. And so this idea that we're just going to disclose performance and everything's going to work out, not really worked out there. So the next thought was, well, what we ought to do is we ought to disclose how much things cost. We ought to let people know how much things cost. And the first illustration here, this comes from the Boston Globe. Boston Globe wanted to publish, and the state encouraged them to do, they wanted to publish how much it costs at various hospitals around Massachusetts, how much it costs to get certain procedures done. And there was something really interesting. I was a medical director at the time, and they came to us and they said, we want your cost data. We said, we don't want to give it to you. And they said, no, we want your cost data, and we're the state, and you have to give it to us. So we did. And the insurers were pushing hard. They said, we want this published. We want this out there. And 2 weeks before the Boston Globe was going to publish it, all the insurers wrote a letter to the Boston Globe and said, please don't publish it. Please take that back. We didn't really mean it. We don't want you to publish it. Well, why is that? Why did that happen? You can see here, this is looking at, we'll just focus on bypass surgery. For bypass surgery, the average cost of bypass surgery to the insurers at the Massachusetts General Hospital is $51,522. And when you look at a matched group of similar patients who get their surgery at Boston Medical Center, it used to be called Boston City Hospital, the cost is $34,000. $34,000 versus $51,000. That's a big, big difference. So why didn't they want it published? Here's a thought experiment to you. There are 2 buses right outside, out front here. Go out the doors to the auditorium. There are 2 buses out there. I'm going to make a deal with you. You're going to each pay me $400 to get on a bus and take a ride. You can call it fare, maybe we'll call it a copay, but to get on the bus. That bus is going to take you to a store. And when you go to that store, you can gather up everything that you can carry in an hour, get back on the bus, come back here, and it's yours. Whatever you can get. Okay? Now, there are 2 buses parked out front. $400. You pay me the same to get on the bus. One of the buses says Walmart. The other bus says Neiman Marcus. Which bus will you get on? Why didn't the insurers want this published in the Boston Globe? The health policy wonks have a name for this. They call it the Neiman Marcus effect. And the Neiman Marcus effect is I say, you know something, my deductible is $400 and maybe my maximum out-of-pocket expense is $2,000. That's a whole lot less than $34,000, much less $51,000. So you know something, I'm going to go to the Mass General because they must be doing something better if they're that much more expensive. So the transparency thing gets complicated too. Now there's a new wave of transparency, and you know it's worth taking 2 minutes and on your phone or on your tablet. Take a look at this company. The company called Castlight.com. What Castlight will do is Castlight allows you to come and see me. I'm a primary care internist. And what they allow you to do is after you go and see Dr. Meurer, and Dr. Meurer says, you know something, you need to have an MRI. You can go on Castlight And if your company is a Cast-Light subscriber, what it will tell you is say, you can go and get that done at Dartmouth-Hitchcock. You can get that MRI done there, but you're going to save $300 if you get it done at this other place. So it is real-time information at the point of care that's directly impacting my out-of-pocket expenses. That's going to be pretty disruptive. So that's the way this transparency thing is going. But with that said, that really isn't enough to get the value that we need out of healthcare. Not as much as a driver as anybody thought. The quality thing is complicated, and boy, even the cost thing, the way this gets interpreted by the public sometimes can be a little bit perverse. So the next notion was, well, maybe what we ought to do is try to drive this by pay for performance. And we're still, all of us are working in a kind of an era of pay for performance, and that era really started quite early in the marketplace that I'm familiar with in the Northeast, and other parts of the country are lagging behind. But we're all in this era of pay for performance now. And as many of you know, that what pay for performance, the fundamental idea here was that in the past, that if I had a great program that was going to improve the care of my patients who have diabetes, that if I initiated that program, let's say it was community group visits, that the patients would win because they would get better control and probably safer control. The employers would win because they would be paying lower out-of-pocket costs over time. And in the end, I lose. I lose because I'm paying for that program up front. I'm not getting reimbursed for that care. Another way to think about this, there was a study that was done about 10 years ago. It was kind of a thought experiment. What they did is they said, let's imagine that all the patients in Eastern Washington State with diabetes woke up tomorrow and got perfect diabetes care. So they took that population of patients with diabetes in Eastern Washington State, the Spokane region. They said, let's imagine they get perfect care. And they modeled that over what would happen over the next 20 years. And what they found was that if that occurred, that in fact, there was a longevity benefit. There was actually a mortality benefit to the patients over that period of time. There was a huge benefit to the payers. And in fact, there was a benefit mainly to one payer. And that one payer is Medicare. The reason why is as soon as you develop end-stage renal disease from your diabetes, you flip over to Medicare no matter what age you are. And so they actually ended up saving a lot of money. And all the providers that they modeled, they went bankrupt. And they went bankrupt because they paid for these programs to get diabetes care perfected, and they didn't get the heart disease and the dialysis patients and the vascular surgery patients in to their doors to keep them afloat. And so pay performance tries to change that equation from kind of lose-win-win to win-win-win. It says, well, let's actually reward people for performing well. We're going to make it worth your while. We're going to give you a bonus. We're going to give you an acknowledgement that you're doing this. And many of you know that we've done many things over the last 10 years, everything ranging from focusing on utilization in the emergency room and pharmaceuticals to thinking about improving the metrics for our patients with high blood pressure or diabetes, or improving prenatal care, to adopting medical records. All of these have been subjected to pay for performance over this time. And when you think about, how much does it take to get traction? This is just looking at just one hospital with which I am intimately familiar. How much does this matter to us? When you look across just 5 years' time, it's worth $145 million. Well, $145 million to a $1.4 billion healthcare organization, that gets our attention. When our margins are less than 2%, you're talking about, several percent a year. It matters. So it's now grown to the point, largely through CMS, it's grown to the point where we do need to pay a lot of attention to it. But pay performance has gone even further. And two examples here. And the first is on your left. This is a letter that went out in 2012 to everyone that was insured by Blue Cross and Blue Shield in Massachusetts. Went to everyone's homes. And basically what it says, some healthcare providers, they cost more than others. And we just want to let you know that. And by the way, you can go wherever you want for your health care. But if you decide to go to one of these places that cost us a little bit more as an insurer, you're going to pay a little bit more. You're going to have to pay a little bit more out of your own pocket to do that. And they sent everybody a list. And on that list, among others, was the Brigham and Women's Hospital right here and the Mass General. We didn't worry a bit. Not a bit. We were the Brigham. We were the Mass General. People are going to come. May have been a little bit of hubris. But also on this list was the University of Massachusetts in Worcester. They don't have that kind of reputation. They're a solid place. They saw their inpatient volumes fall off 30% in a year. 30%. Whoa. Now there's a way to take it a little bit further. This is like the bonus question. Does anybody know what this is? What that object is? The Code of Hammurabi. Code of Hammurabi. Anyone know where it is? You can actually go see it. It's cool. It's in the Louvre. The Code of Hammurabi is in the Louvre. And if you were really good with ancient languages, you'd be able to translate part of the Code of Hammurabi. And the reason why I show this is the context for this is this part of that slide, it's not mine. It's not my intellectual property. I actually borrowed it from somebody with their permission. The person I borrowed it from is Jack Rowe. Jack Rowe used to run Aetna Insurance. Jack Rowe was a physician and was the chief executive of Aetna Insurance. To put things in perspective, his last year at Aetna Insurance, his income was $38 million. That did not include his stock options. $38 million. And he showed this slide to grand rounds at the MGH. He said, this is where he thinks health care is going. He showed this Code of Hammurabi. And if you were good in the language, what you'd see the Code of Hammurabi says, it says, if a doctor opens with a bronze lancet an abscess of the eye, and he cures the eye, you get 10 shekels of silver. Now, I don't know what 10 shekels of silver is in 2013 US dollars, but I think that's pretty good. That's worth a few RVUs right there. It's not so bad. So that sounds kind of good. But then there's the next part. The next part says, you know, if things don't go so well and the patient loses their eye, the doctor's hands will be cut off. Okay? Context. Jack Rowe, speaking to grand rounds, saying this is where I think insurance is going. What he was saying is he was saying that the first step is we're just going to tell people it costs a little bit more. And it's going to cost a little bit more to use these places. The second step is we're just going to cut them out. We're just going to, and this is called selective contracting. Selective contracting is more or less kind of the nuclear option. And we're starting to see that in the marketplace. Now, again, it's very difficult to selectively contract against somebody with a high reputation in a community. It's very difficult to contract against a Johns Hopkins or say you're not going to pay a Mass General or not going to pay a UCSF or maybe not pay a medical college of Wisconsin. But the truth is that that is a very powerful tool that you can use against many other folks in the community. And so pay-for-performance is morphing on a little bit. There's some more kind of draconian, stronger change that we're seeing. But even that really hasn't generated the value yet, right? People have to, and so the next step, the good news here is that I can explain the Affordable Care Act in a single slide. So any questions? Right. So this is the Affordable Care Act in a single slide. And actually, you can get this. This was produced by the Joint Economic Committee of the Senate. And what they've done is in a single slide here, or a single graphic, and you can blow this thing up. It's a high def image. You can pull it off the web. Just search on the Joint Economic Committee, U.S. Senate, Affordable Care Act graphic. You can pull this thing up. It's incredible. And the interesting thing about it is I actually have a big blown up version of this in my office, and because I actually can just say, okay, how does somebody get on the Patient-Centered Outcomes Research Institute Advisory Committee? You can actually look and say, oh, there's P. Corey, and here's a little piece that talks about how you formulate, and it has a section of the law. You can go to the law and see what it does. So this is actually completely accurate. What's so ironic to me is, for those of you who are a little bit older, you'll remember that during 1993, when Clinton's healthcare reform came to the floor of the Senate, Bob Dole held up this chart, and he said, this is, and it depicted a flow chart of Clinton healthcare reform, and he said, this thing is way too complicated. We could never do this. Well, I mean, that flow chart looked like about that, right? Like that was the flow chart right there. So things have evolved over 20 years. The other bonus question here is was this created by the majority of the staffers that created this? Were they the Republican staffers or they were Democratic staffers? It was bipartisan, but one of them had a majority in terms of creating this graphic. Who was it? How many think it was the Republicans? I think it was Democrats. Okay? Republicans. Republicans, you know that because patients are marginalized here in the corner, the president is pushed up into irrelevance, and Catherine Sebelius is made to look like the queen of the universe. And so there's definitely, but it is completely accurate. But when you dissect this out and say what's really happening on the value front, the big difference is here, this notion of moving towards a triple aim of trying to improve outcomes for patients, trying to improve their experience, the culture of caring that they are going to experience while they're in the healthcare system, and doing that for the lowest per capita cost. That's the main driver here. And many of you have lived through that transition of kind of traditional fee-for-service to the inpatient setting to DRGs, and now we're just taking a really dramatic step forward. And what that really means for those of us who are managing healthcare organizations, the way you manage a healthcare organization until recently was pretty simple. With all due respect to those of us who have all those advanced degrees in management, I think it was pretty simple because there was this triangle. It was the iron triangle. The iron triangle was volume here, rates, and unit cost. And what you tried to do in running an academic health center is you said, I want to make a 2% margin or whatever it is that you feel that you need to make to be viable, make the capital investments to keep you a thriving organization. What you would do is you try to attract enough patients. When you couldn't do that, you tried to demand higher rates from the marketplace. And if all else failed, you just cut your costs. Right? That's the way that we manage healthcare over the last 50 years. But when you go back and you look at this kind of new dynamic here, that the new iron triangle is actually, we need to really work on quality, safety, efficiency. Genetics and genomics are coming over the horizon. We're not going to talk about that today, but I'm happy to answer questions about it. And getting patients engaged, that's the new dynamic. That's what's so dramatically different. And when you say, well, how does that break down? There's a lot about quality and value that has nothing to do with the individual mandate, that wouldn't be affected in any future Supreme Court decision. And frankly, many of these would be pretty hard to defund. And that when you look at these, over these 5 years, moving from kind of traditional fee-for-service down to paying physicians based on value, not volume, this is a dramatic change. And so many of us are working on redoing our compensation plans for the 4th time in our lives or 5th time in our lives. Why? Because that notion that we didn't get far enough. We tried performance reporting. We tried pay for performance. We tried that consumerism and selective contracting and the rest. It didn't take it. We need this broader, bolder change. And one of the things that I always remember about this is that there's a lot of these different experiments going on, and I'm not going to go through each of these, but I remember that when I was working in the Clinton administration, I had some of the smartest health economists in the country, and they came up to me and they said, hey, Gregg, I'll tell you a secret. There's a right way to pay for health care. The right way to pay for health care is capitation. If only we can deal with measuring quality and ensuring that patients get needed services, and we can risk adjust it, capitation is the right way to pay for health care. Now, 12 years later, I was working in a different administration in Washington. I had equally smart economists come up to me and they say, hey, Gregg, there's a right way to pay for health care. That way to pay for health care, fee for service. Let the markets work. If only we can deal with overutilization, that's the right way to do it. The conclusion I've drawn from all that is if anybody tells you there's a right way to pay for health care, or we're only going to be paying for health care one way, they're delusional. There's no right way to pay for health care. If I think about the work that I do as a primary care physician in looking after somebody's wellness versus the work I do in managing an acute self-limited illness like pneumonia versus looking at somebody with a kind of episodic care need like an episode of breast cancer versus what I need to do in managing a chronic care episode like a patient with diabetes versus the work I do in looking after somebody while they're inpatient in the hospital. Those are all very different types of work, and we probably will be getting paid very differently for them. And so one of the things that I find myself doing is trying to explain to my colleagues that it's very easy to get caught up in this notion of how do we get ready for accountable care? How do we get ready for capitation? How do we get ready for taking on new risk? That's not what we need to work on. If we take great care of patients and we do it as efficiently as possible, no matter what happens with the payment environment, we win. So how do we do that? How do we actually take great care of patients and do it as efficiently as possible? And it ends up, if you look at the literature, there are only about 20 or 21 things that have really been shown to really work. If you want to take great care of patients, you want to really improve your efficiency. And one of my former colleagues at MGH, Tim Ferriss, kind of captured all of these. And you can see them here across the spectrum of care. Each of these interventions has been shown to improve quality of care, increase efficiency. These create value. This is our job. Our job isn't to get ready for affordable care. Our job isn't to get ready for capitation. Our job is to provide great care as efficiently as possible. And these are the tools that we have that we know will work to do it. And I want to spend a couple of minutes just talking about a few of them. And many of these you know well, but this is going to be our work as we move through this transition of trying to help improve the value in our healthcare system. And the first I want to focus is just this notion of defined process standards and priority conditions. This is the work that many of you are involved in, yellow belts or folks who are trained in lean, who are doing work and trying to improve our processes. And kind of the groundwork for this is relatively well known from other industries. And here's a paper that was written by Tom Lee in the New England Journal that said, how do we put this value framework to work? And the answer is we look at what other industries have done. Everything from Toyota and Gary Kaplan's great work in Virginia Mason to what we can learn from our colleagues at GE and their Six Sigma. We know how to do this. And I know that you were involved in this work. And one of the real keys here, though, is having the data, because sometimes where we need to work is a little bit counterintuitive. And this is data that comes from some analyses that we did several years ago. And what this looked at is, this looked at a group of about 3,800 or so patients with diabetes. One of the things that we talked about, what we need to, if we want to really try to improve the value in diabetes, what we need to do is we need to drive the hemoglobin A1C down as low as we possibly can, as safely as we can, and we need to improve the quality of the encounter. We need to do group visits and all those things. And those are important. But if you actually look at the data, if you really want to improve value, focus on pharmacy. Focus on those drug costs, on using those high, those expensive oral agents, moving patients to insulin faster. Right? That's how you really, really improve value. Looks a little different when you look at something like total knees. And so this is data that comes from the High Value Healthcare Collaborative. I will tell you that Dartmouth-Hitchcock is O here. And these are a group of academic centers across the country. What this looks at is the post-acute reimbursement, how much it costs after the patient left the hospital. And what you can see is incredible variation here. So you can see in one place it costs almost $19,000 in post-acute care costs, and much of that was spent on inpatient kind of rehab here. Now look out here. These folks actually have some of the best outcomes, lowest infection rates, lowest readmission rates in the country. So it's not that they're skimping on the care, it's not that their patients are well, but these folks have figured out how to do this and cut that huge cost out. So using the data to drive this, sometimes it's not going to be one solution. It's not all about looking at post-acute care. It's not all looking about pharmacy. It's having the data to understand where to target the intervention and recognizing that we have a consistent methodology to apply. We're going to be applying it at different targets. That's our work over the next couple of years. Another space where, again, there is great evidence that we can do this is looking at our high-risk patients. And what do I mean by that? I'm a primary care physician in an academic center. I don't have patients with hypertension. I don't have patients with heart disease. I don't have patients with cancer. I don't have patients with depression. I don't have patients with arthritis. I have F, all the above. Those are my patients. And as we think about them, we know that there's that 5% of patients who really are the majority of the time. We need to take care of everyone, but we really need to focus on the few. And this is the few, and this may be hard for some of you to see in the back of the room, but this is actually, this is a patient, And the patient is sitting at a table filled with her medications. She had 11 specialists. Her cardiologist was terrific and had her heart failure tuned perfectly with 5 medications. The psychiatrist did a great job with her depression. She wasn't suicidal anymore, taking 3 meds to do it. Now, the rheumatologist did a good job with rheumatoid arthritis, but she was giving herself an injection every few weeks and had to still take some nonsteroidals on top of that. Oh, her cancer was in remission, but she still had to take this pill every day, this hormone-related pill every day. And so it went for this patient. This is not made up. This is real. Now, the first thing to think about when you look at this is for us to really be honest with ourselves as healthcare providers. And this is just a little bit of an honesty test for all of you in the audience. So I want you to raise your hand if you can take a 3 times a day antibiotic for 1 week perfectly. You raise your hand if you can do that. Liar, liar, pants on fire. I don't believe you. But even if you can, the notion that we ask 70-year-olds and 80-year-olds to do that, that's delusional. We are crazy. Right? That's not possible. We can't do 3 times a day antibiotic for a week. We expect them to do it. Now, another way to look at this is I actually had the pharmacist quantitate this. Look at each of those prescriptions. And there's a Geico commercial, and it's a wad of cash with eyes on it. That's $10,000 sitting on that table. That's $10,000 sitting there. And what we did in a program, the Mass General Care Management Program, is that what we showed is by embedding a care manager in the practice, by making it easier for patients to access behavioral health, by having somebody coordinate the way that they interact with community services, by having rides arranged for them to get in for their care, guess what? It works. It works. And this isn't our analysis. This actually comes from the Congressional Budget Office. The Congressional Budget Office looked at our demonstration program, and what they said is you know something? We got most of the folks to enroll, that their ED visit rates were lower, that their hospitalization rates were lower. They had a 4% mortality. These are sick people, right? These are the people who are the ones that keep us up at night. There was a 4% mortality. If this was a pill, if this intervention, this care management program was a pill that you took, that ethically that randomized trial would have been stopped. A 4% mortality benefit would always trigger a stop rule. So it would have been stopped. This is powerful stuff. And we saved 7.1%. After all the costs of the care manager, behavioral health specialists, and doing those rides, we still saved a net of 7.1%. Or for every dollar we spent on the program, we saved at least $2.65. We can do this. We know how to do this. The recipe is there. We need to apply it. We need to do it in a disciplined way. But we do know how to do this now. So that's another important lever for us to pull in value. Another one that we spend a lot of time on at Dartmouth-Hitchcock is shared decision making. And this gets to that part of that value equation. I always remember when someone says, value is it's just about quality divided by cost. I always think, doesn't always work that way. So for those of you with really good memories, you might remember this story. So there was this place in Northern California that was doing bypass surgery. And their outcomes were terrific. The patients did really well. Never got a mediastinitis. They returned to work really quickly. Their length of stay was low. They really went through their surgery with flying colors. The costs were really low too. It's really efficient. In fact, the patients would say, I came in the morning to see my doctor, and by that afternoon, I was done with my bypass. Didn't even know I was going to have it that day. Does anybody remember where that was? It was indeed. Remember 60 Minutes. And what was tell me about those patients. What was interesting about them? They didn't have coronary artery disease. Exactly. So that's why when someone says, this value is quality divided by cost, under that equation, they were doing a terrific job out there, right? The outcomes were good, and and they were doing it really. So appropriateness is really important. Appropriateness can't be ignored. And I always think about Redding, California, whenever I think. And so how do we make sure that what we're doing is appropriate? Because we're not the judges of that. We're the judges of that with our patients. And again, we know how to do this as well. And so we know that by making shared decision-making available, so when I see patients at Dartmouth-Hitchcock, embedded into my Epic record is the ability to immediately refer somebody to our Center for Shared Decision-Making. They'll either get a video or they can come and actually talk to a counselor who will help them decide what they are going to do in terms of advanced care planning for end of life, whether or not they want their PSA tested, should they have colonoscopy or not, should they get adjuvant treatment for their breast cancer, do they need total hip or total knee replacement, among many others. So we've built this out across an array of diagnoses and integrated it into the workflow. That's the key, is that we make it easy. Doing the right thing is the easy thing. I don't have the PSA talk with patients anymore. I don't have it. I don't have the hormone replacement talk with patients anymore. And I have to say, as a primary care doc, I don't miss it a whole lot. Because maybe I wasn't so good at it, and even if I was good at it, it got kind of boring after a while. And the truth of the matter is patients do much better when they have a very objective source they're working with that can answer what it means to them personally. And what we know is that when patients are really informed of their options, in fact, the utilization goes down. So we found overall about a 20% decrease in the use of elective surgery. These are things that were not going to be of value to the patient because their preferences suggested that they were not important to them. And I always remember one of the discussions I had with a patient was around his end-of-life care, and I said, well, what do you really want? And he said, do you want to, if you come to the hospital and you have your heart stops, do you want us to bring you back? And he said, Doc, all I want is one thing. He said, I just want to be able to eat ice cream and watch baseball games. And if I can do that, and you're going to be able to help me do that, then I want you to do everything you can. And if I can't, I don't want you to do anything anymore. I knew his preferences. It was very, very helpful to me. And unfortunately, shortly thereafter, he was in a state where he was not going to be able to eat ice cream and watch a baseball game. And we made the right decisions about the prolongation of his care. There are also some incredibly untapped opportunities. And so there's those things that we know, those 21 interventions, and we just need to get to work on them. But then there is what I think is the most exciting part, and this is where I have the privilege of spending much of my time, and it's really hearkening back to what all of us learned in medical school. And all of us learned in medical school that, in fact, what we do, despite our exquisite training and the amount of time, energy, and effort we put into it, and how important it is to us personally, that what we do actually is a relatively minor contributor to whether or not a person says they're healthy. Right? So if you actually look at the determinants of health, and you all know this, that in fact, fully 40% of it has to do with behavioral patterns, has to do with whether or not somebody's exercising, has to do with whether or not somebody chooses to smoke cigarettes. Another 5% is their physical environment. Are they living in a healthy place? Do they have access to healthy water? Socioeconomic status plays a role. Genetics plays a pretty big role, and we can't influence that quite yet. But what we do in healthcare is about 10%, maybe 15%. This is our opportunity. Here's our chance. So it's not just taking care of the patient in front of us, it's thinking about the patients out there. Not the patients we're taking care of today, but the patients care of tomorrow. So population health. Population health is going to be a big driver of this value equation as we go forward. So we think about where we started. We started saying, boy, we can't afford this situation. We're in the land of diminishing returns. Costs are going up like this. Outcomes are kind of flat. It's a big deal to employers now. They're all thinking about it. They care about it. They're paying attention. They're asking us for value. We started trying to do that by just disclosing performance. Didn't work out quite as well as we thought. We thought pay for performance would take us a little further. Maybe it did. But now we're really trying to re-engineer care and do these 21 things that are going to improve value. But pushing forward to population health is the next piece of this. That's the next part of our work. What's it going to take to do that? And I do think what's going to take to do this is a paper that several of us wrote a couple of years ago. And what we talked about is this notion that we are undergoing in this punctuated equilibrium, this dramatic change. And when I think about when I began my training after medical school, I can remember that the people that I looked up to and the people who I thought were the good doctors were those who had this encyclopedic knowledge. There were folks who were, did whatever it took to take care of that patient. They were focused like a laser beam and singularly on what happened with that patient. They were the lions. They were the folks who you said, my goodness, they're the ones that we want to be like. I don't want to hire them anymore. I don't want to hire them. If you ever run into a colleague, or more frightfully, a physician caring for you or a loved one, who claims to have an encyclopedic knowledge and doesn't look things up, run. Run. We need to know how to manage knowledge. We know how to access knowledge. We can't be encyclopedic anymore, no matter how smart you are. The physician kind of is the lone wolf, the person who will do whatever it takes. We need to work in teams. We can't do this alone. The physician who focuses on that singular patient in front of them, that's really important, and we need to do that. That's the Hippocratic Oath that's sitting right outside the auditorium here. But that's only a piece of it, because we're also responsible for all those who have not yet accessed our care. We are responsible for the horrible statistics in the neighborhoods that surround every academic health center in the country. It's not a Milwaukee phenomenon or a Boston phenomenon or a Baltimore phenomenon. It's a national phenomenon that we need to think not just of patient. So we need folks who are thinking about quality improvement, about population health. Those are the physicians that I want to hire. I want to hire the person who knows how to access knowledge. I want to hire the person who works on a team. I want to hire the person who realizes that they may not always be in charge of that team. I want to hire the person who understands how to use the tools of population health. That's what we need for the evolving healthcare marketplaces. That is the new good physician. And that is a dramatic change. That is punctuated equilibrium. That is rapid evolution over a short period of time. And so one of the things I conclude with here is just that we're likely to experience this for years to come. This is the new normal. Things have changed. That we're not going to go through this for a year or two and it's going to go away. And we have colleagues who kind of say, well, I'm just going to hunker down and let this stuff pass. I'll just continue doing my thing. I just won't raise my head up very high and everything's going to be okay. It'll all pass over me. That's not going to happen. In fact, this first wave of healthcare reform, whether or not it comes from Baltimore or comes from Washington, or I think most healthcare reform is going to come from places like Concord, New Hampshire, Madison, Wisconsin, Sacramento, California, and from communities like Milwaukee and Boston, and maybe even Hanover and Lebanon and New Hampshire. That's where healthcare reform is going to come from, and they're going to be focusing even harder on this notion of value. So finally on that, just to leave it on a different note, the good news is those of us who work on quality, we will be fully employed as we continue to go through this evolution and this transition. And the caption here is, the race for quality has no finish line, so technically, it's more like a death march. So we will be fully employed in the future. Thank you very much.
We have time for a few questions for Dr. Meyer, and then there's a reception down the hall afterwards.
Please. Oh, I think you need the microphone. Just.
Thanks very much. I'm Bruce Campbell. Are there any international models we could be looking to that have answered the value question?
Yeah. So just this last week, there is a terrific, really short, not dense. There's an article in Harvard Business Review that you can get online for free, written by a guy, Vijay Vanyaratnam, who's a Dartmouth professor. And what he talks about is his work in kind of this notion of reverse innovation. So what he's done is he's spent a few years in places like the Aravind Eye Institute in India. The Aravind Eye Institute right now is doing more cataract surgery than any place else in the world. Now, part of it is people say, well, yeah, and they're getting great outcomes, right? And they're now JCI, Joint Commission accredited. They're getting really good outcomes with their patients, low infection rates and all the rest. And the costs of it are super low, right? So they're averaging about 4 to 8%. Now, it's fair for you to say, well, of course they're so low because the doctors are paid so much less. Well, the ophthalmologists are paid less, not as much less as you think, actually. They're probably paid like 40 to 50% of their U.S. counterparts, but it's not 10%. Well, their staff is really low paid. Their staff is really, really low paid. But actually, if you took their input costs, you took their labor costs and made them the exact same as U.S. labor costs, they're still about 75% cheaper than we are because they're doing things differently. So they're doing things with where they have their setup there involves the surgeon who literally sits in between two tables with people who are focused on just kind of prepping the eye and finishing off the surgery for them. Very, very efficient models. Another place to look at is there is a heart institute. And this is something that I think that has many folks here kind of a little bit concerned, a little bit worried about the future because there is a heart institute in India that again has had superb outcomes from bypass surgery that has very low length of stay, incredibly low resource use. And what they are doing is they're opening a hospital, I think it's 200 beds, a 200-bed heart hospital in the Cayman Islands. So this idea of reverse innovation, there's a lot to learn. There's a lot to learn. And I think and I'm blessed because Dartmouth, Vijay is one of my colleagues. He's at the business school at Dartmouth-Hitchcock and is someone I've heard a lot from over the time. But the reality is I think that in the past we used to send medical students off to do their rotations in Rwanda or in Kosovo or in India, and we felt that this was an important part of medical education and global health and getting an appreciation for those. Well, something, what we ought to be doing is when they're coming back, we ought to be sitting down and debriefing with them and saying, what can you teach us? Because I think there's a lot to learn from a lot of those settings. That is going to be a very, very important kind of activity, I think, over the next 5 years or so. And we'll be interested to see that the notion of travel medicine really didn't blossom into what people talked about. So 5 years ago, there was this notion everybody's going to hop on a plane and go to India, they're going to go to Thailand to get their surgery done. There's some of that now, but by and large, the travel costs and other barriers, people don't want to travel at a vulnerable time in their lives, haven't made that happen. But what we can learn and pull back in from them, I think is going to be really powerful.
Chuck Durkee, comment first. T.R. Reid, The Healing of American Healthcare, I thought was a fabulous book that gets to Bruce's question as well, where he traveled the world to, I think, about 13 Western countries and stayed long enough to utilize them. And there was a lot to learn, including how we're aligned with the insurance industries where he was finding differences and commonality. And then my question is, how do we control the ever-increasing cost of technology that clearly are going to have and will continue to?
Great question. And I think one of the things that's important to remember is that if you actually look at the drivers of healthcare inflation, said earlier, the healthcare is going up 2.5% more than the consumer price index. If you look out over the last 40 years, what are the drivers of healthcare inflation? That most of you will appreciate, and for those of you the students, I don't want to burst your bubble, but it's not that physician salaries are going up. It's not that even that nursing salaries are going up. There have been three big drivers. And the three big drivers are a little bit surprising to some. One of them is something I mentioned a little bit earlier, is imaging. It ends up that imaging is actually one of the major drivers of healthcare costs. And I always remind myself there is no satiety to the desire of Americans to see what the inside of their body looks like. That I've never had a patient say, no, I really didn't want that scan. The second big driver is one that we all kind of associate right away, and that's pharmaceuticals. But pharmaceuticals are now number two, and number one is our medical devices. And so that $68,000 defibrillator made in a state north of here that will go unnamed, that we're putting into patients to give them 4 months of improved quality of life with their heart failure, that is a huge driver. It's such a driver that, in fact, there's a Princeton economist guy, Uwe Reinhardt, who's written a lot about healthcare economics. What he would argue is that many people beat up the United States and say, the United States is a bad global citizen. We're not pulling our weight. Because if you look at the investments that we make in development around the world, they are relatively small as a percentage when you compare them, for example, to our European counterparts. They do a lot more investment in economic development in the third world. And what Uwe argues, he says, you know, the United States is more than pulling its weight, because by the high prices we pay for devices and pharmaceuticals that are developed for the rest of the world to eventually buy cheaply, that we are in fact subsidizing them, and we're making more contribution in their development than all those European companies put together. So there's a lot of money. What's going to drive that? I think a couple of things are going to drive getting it under control. I think the first one is for us to start asking harder questions. And one of the things I think that I was a little bit taken aback by when I arrived at Dartmouth, which is a place that prides itself on really focusing on efficient care, that when I said, well, you know, what's really exciting? What's going on here that's new and really exciting? One of the first things they did was they showed me the plans for our Center for Surgical Innovation, which is about to open. And it is an amazing facility. And it's a pair of operating rooms, and those operating rooms have CT scanning and MRI that roll in and roll out, that can be kind of housed so you can pull it in the middle of the operation room. It's also interesting in that it is a facility that actually allows you to do, in these same operating suites, surgery on both humans and on animals. So it's a testing facility. But you know, here it is. This is like this incredible technology that's going to be really, really expensive. Oh, this is the direction that we really need to be going for trying to create a sustainable health system. But what they're actually doing is they're using it as a laboratory. In the laboratory, the study is saying, where does this really make a difference? What are those conditions where we can show that having this technology brought to bear? So I think there's going to be a lot more scrutiny about this. If I were looking for a place as a health service researcher, so where can I find funding in the next decade or so? I think this whole notion of going back to that era of, we used to have the Office of Technology Evaluation, that we will be doing more work in technology evaluation. I also think, though, that the manufacturers are starting to understand that they need to drive these costs down. We have a conference each year in Dartmouth that attracts the FDA, it attracts folks from CMS, it attracts venture capitalists, it attracts bankers, it attracts cardiologists, vascular surgeons, and cardiothoracic surgeons, and manufacturers all in one room to have an open dialogue about what's happening. And I've watched that conference over the last 4 years. And like I say, the difference is that people are now really focusing, how can we do this more cheaply? So I do think in some ways the technology companies are going to have to heal themselves. With that said, we are carrying a big, big burden for that for the future. Thank you very much.